Turning on to Dr. Ganti, can you comment on the recent progress in treatment of extended stage small cell lung cancer with the availability of immunotherapy plus chemotherapy combinations?
Sure. Small cell lung cancer, especially extensive stage, was in need for some advances in the treatment paradigm. For the last 25 years, we've been using platinum and etoposide as our backbone regimen. And till recently, there was no other treatment that was shown to be superior to this combination, and it was not for lack of trying. The first study that showed a benefit over standard platinum etoposide was the Empower 133 study that showed that adding atezolizumab, a checkpoint inhibitor, to platinum etoposide increased overall survival. And since then, there have been at least 2 other trials. The CASPIAN study that showed that adding durvalumab to platinum etoposide was better than platinum etoposide alone. And more recently, at the ASCO annual meeting a couple of months ago, the addition of pembrolizumab to the same platinum etoposide backbone regimen was associated with an improved progression-free survival as compared to platinum etoposide alone. And a smaller randomized phase 2 study that looked at nivolumab with platinum etoposide showed the improvement in progression-free survival and an improvement in overall survival with the addition of nivolumab. So we have 4 trials with different checkpoint inhibitors that suggest that adding a checkpoint inhibitor to platinum etoposide is better than chemotherapy alone. Of these 2 drugs, durvalumab and atezolizumab have current FDA approval in this indication.
Thank you so much. Do you have any comments, Dr. Shang?
Sure. I think this is a very exciting time, as Dr. Ganti said, for small cell. We've had several approvals in the past year, and that compared to 30 years of no approval. So we're very excited. The Empower 133 trial and CASPIAN trial have really defined the frontline standard of care. The Empower 133 trial showing about a OS of 12.3 months versus 10.3 months and a hazard ratio of 0.76. And then the updated CASPIAN data just presented at ASCO showing 13 months versus 10.3 months overall survival with a hazard ratio of 73 or 0.73, excuse me. And I think interesting, the point made on the CASPIAN trial is that the separation of curves at 2 years, that survival improved from 14% to 20% on the experimental arm versus control arm. So I think that tail of the curve is something that we are really excited about and looking for this population, which clearly doesn't have the median overall survival is about a little over a year. So we definitely need more research and ongoing investigation into new therapeutic agents and options. But the addition of immunotherapy does help us have hope that there are some patients who can have really long-term survival. For the CASPIAN trial, the combination of tremelimumab and durvalumab did not help, so adding that anti-CTLA-4 antibody did not help. And then just a word on Keynote 604, which was the Pembro trial. This was not a statistically significant, but certainly did have the overall survival and progression-free survival trends in the right direction. So it looks very promising, but just did not, because of the way that the study was constructed, did not have statistical significance. And obviously the Nivo platinum etoposide trial, ECOG-5161, was a phase 2, but looked promising. That was the primary endpoint was PFS. And then I think the last thing that I would add right now is just that, we have a couple of options up front. How do you decide? It's not absolutely clear that one is much better than the other, which is great. I think we have options for our patients. I do think that one of the differences in the CASPIAN trial was that it did allow asymptomatic brain mets. So if I have a patient who does have asymptomatic brain mets, I might be more inclined to use that Durva regimen in combination with chemo.